Welcome to the symposium on progress and promise in prostate cancer. Our sponsors here, their supporters are Bayer, Dendreon, Endo Pharmaceuticals, and Janssen, who have generously allowed us to create this presentation at the end of a very inspiring 2 days conference sponsored by the Society for Translational Oncology. I'd like to begin by asking all three panelists to contribute to this question, but maybe we can start with Johan, and that is, and I'm sure you can anticipate this, it seems like in targeted therapy, the progress that we've made has come through understanding the molecular subtypes of disease and the drivers of those subtypes of disease. You've alluded to that in prostate cancer. In fact, you showed us a slide with 22 different molecular subtypes. But that's a little complicated. Do you think it's going to be that complicated, or is it going to be something relatively simple, like mutations involving the PI3 kinase pathway versus RAS, RAF, MAP kinase, MEK, and so forth? It seems like it's a very important question in taking the next step toward selective therapy. So what are your thoughts about that, Johan?
With regards to our dream of actually eventually treating men with prostate cancer without castrating them, which must be our ultimate goal, and curing them of cancer, I think we will have to focus on, for example, drugs targeting ERG or ERG signaling. So that will require, or maybe ETV1, 10% of prostate cancers, that will generally require truly molecularly characterized disease.
Are those druggable targets?
There is emerging evidence that one can drug, for example, ERG by inhibiting PARP. There was a paper published by the Chinian group in Cancer Cell in May, for which I wrote the editorial, where they showed that PARP directly interacts with ERG and is a key transcriptional modulator of ERG. In fact, PARP is a transcriptional modulator for maybe many targets, many transcription factors, including maybe the AR. But if I back off somewhat from that vision, which maybe is the longer-term vision, the increasing evidence biologically is that actually prostate cancer may be, at least in part, induced by androgens. And androgens may in fact be carcinogens indirectly by binding AR actually binding to AR response elements, binding sites, inducing double-strand breaks to topoisomerase 2 beta, which are normally actually re-annealed in a normal fashion. But actually what is emerging is that actually in some cases where perhaps there may be inadequate repair or an underlying DNA repair defect, perhaps due to loss of NKX3.1, you actually emerge with, at that response element, AR response element, a DNA double-strand break, non-homologous end joining, and perhaps through a stochastic process, rearrangements of a AR-driven promoter to the oncogene like ERG. And that data has come from multiple groups, particularly the Hopkins group. And I think the evidence for that is really quite strong. You can now induce rearrangements, ERG rearrangements in cell lines that are ERG negative, just by high-dose androgen and radiation therapy. And what is apparent is that actually loss of homologous recombination repair, but proficient, low-fidelity, non-homologous end joining is key to accelerating that process.
Generating the downstream mutations.
Yes, so I think in that setting where androgens are causing rearrangements that are androgen receptor driven, perhaps hormonal therapies will not require the more broad, the patient's selection. And that's why abiraterone works so well, both in the ERG rearranged and unrearranged patients. But I think if we truly want to get down to hitting some of those key drivers, I think we will have to select patients.
Do more detailed molecular studies. Yeah. Any comments from the other speakers about this? Yes. Do you see the possibility of stratification, for example, for the radionuclide therapy?
Well, I think that, having listened to the speakers over the last 2 days, prostate cancer is well behind breast cancer, colon cancer, hematological malignancy in the stratification, in the genetic stratification. But speaking as somebody who's, anybody who works with these patients in the clinic will see a huge variety of disease presentations and disease progressions. So I think the prostate cancer phenotype is very heterogeneous.
Yes.
Like we see patients who don't need treatment at all, right up to patients who are with rapidly fatal disease. We see huge variety of responses to both androgen deprivation, anti-androgen therapy, to cytotoxic chemotherapy. And I think the same is true for radionuclide therapy. So I think it's very obvious that there's a very wide variety of phenotypes. So I think the next step is to start.
And probably repair capability.
Yeah.
So that would certainly influence the radionuclide response. We just haven't used that in selecting patients or trying to organize studies. Any thoughts?
Yes, I think
David?
the only other thing that I would say is that despite that molecular heterogeneity, there may be functional pathways that are common to some of those molecular phenotypes. And so it may be that there are 3 or 4 really key drives in the disease that we can actually start to target in maybe a molecular stroke biology-driven phenotype, essentially.
Well, probably one of the most important things that's happened in the field is the fact that we're now thinking beyond androgens and the role of androgens. Although they're clearly the most important thing therapeutically at this point in understanding the disease, but still there's a lot of biology that is undiscovered here. It's somewhat similar to breast cancer, but the fact that the responses are so uniform initially to androgens has sort of put us to sleep scientifically. But I think that your work and the work that we've heard about here with the cytokines is certainly revealing. What about one other question that occurred to me during the presentations is it seems that this radionuclide therapy has real potential in the sense that it's non-toxic, it's relatively easy to use, and you were cautious about saying it could be used in early disease, but could it be used in patients who are on their first hormonal therapy, for example?
I think that one limitation is that you are, at least the way the drugs are used at the moment, depending on bone turnover to attract the isotope, I think you need to have some activity in the bone. But I think, at the same time, the possibility of labeling those drugs with something a little bit more targeted. But I think probably in the current formulation, it requires some activity in the bone to attract
That's an interesting point. So, using it together simultaneously may not be the way to do it.
But I do think to cure more patients, adjuvant therapy will be key. And I presume that for, alpha-radin and these drugs, osteoblastic reaction in the bone is key. So the question is how early, in that micrometastasis is the osteoblastic reaction, there? Because actually, if you go in early stage patients, has anybody actually looked at imaging, patients who are, say at the earliest setting, high risk patients, to see if the alpha-radin actually goes in the bone in any way?
No, not really, but we have the data from MR showing, that there is a lot of activity in the bone long before the bone scan is positive. Mm-hmm. But no, I don't think anybody's looked specifically at that in early.
Because actually, adjuvant abiraterone is what I'm really excited about. Yeah, but adjuvant alpha-radin makes a lot of sense too.
Yeah. Well, I guess that something like 2/3 of people that have abnormal PSAs but no obvious disease are going to develop bone metastases. Maybe it's even higher than that.
What we're seeing actually, and I think
that might be the ideal setting for using the drug rather than waiting for voluminous metastases and trying to treat them.
And I think one of the biggest problems we have in prostate cancer actually is the use of bone scans. I would actually love to replace bone scans with a better imaging modality that truly reflects, the activity of the disease. I think bone scans have been widely abused. I think diffusion-weighted magnetic resonance imaging and novel PET tracers have to be developed to replace bone scans, because actually all we get with bone scans is a late detection of the presence of bony metastasis.
Increased rates of bone turnover.
And you cannot really differentiate osteoblastic reaction from disease.
And you need quite a lot of disease there in order for that reaction to have taken place. So.
And we're actually with diffusion-weighted MRI seeing in patients with rising PSA and a normal bone scan, multiple metastases in some patients, 50 or more mets, despite a normal bone scan.
One other thing that you mentioned, Joe, that was interesting to me was the fact that because it's relatively non-toxic, the radionuclides could be used with chemotherapy.
Yes.
We thought the same thing with the PARP inhibitors. It turns out that they do accentuate bone marrow toxicity. Do we have much experience with this combination?
Well, there hasn't been much experience today with alpha-radin, although there's a study which has been led by Michael Morris at Sloan Kettering looking at alpha-radin plus docetaxel. Mm-hmm. So 6 cycles of alpha-radin along with 6, actually just combining with standard docetaxel. So
well tolerated?
Well, so far it's only phase 1 at the moment, so it's the BC10 study. But I think there's no doubt that it's amazing. We in a trial where you can't tell who's getting placebo. And it was similar to abiraterone, but you could kind of tell.
Really?
But in this, you really couldn't tell.
What is spectacular is that actually normal bone seems to take up minimal alpha-radin.
Yeah.
Your scans are absolutely spectacular. Yeah. Is that really, bona fide that there's very little uptake in normal bone?
Well, the only people that have really done the microdosimetry has been Glenn Flux at the Marsden, actually. And they have seen huge activity near the metastases, and really it falls off very rapidly.
So it's truly selective, which is,
Well, maybe it just represents the fact that there's much less bone turnover on non-metastatic sites.
Yeah.
So you would expect it.
The PARP inhibitor combinations, and I've done a lot of PARP work, make a lot of sense in that setting. Although I think the right scheduling of the PARP inhibitor will be key, because actually the problem with platinum combinations, and we've done these studies now in phase 1 setting, is actually if you give the PARP inhibitor continuously, if it's an active PARP inhibitor, it's not tolerable with full dose chemo. But actually, if you give the PARP inhibitor in a shorter schedule, intermittently, it will be truly work.
Something. Yeah. Now, is it clear that PARP plays a role in the repair of DNA damage related to the
double-strand breaks?
For sure. I think it's ionizing radiation. It's double-strand breaks. I think it's pretty clear.
Really? Yeah. Gee, that would make a lot of sense. Yeah.
It's a slam dunk. We got to do
Where's
it.
our?
We pitched this to a few pharma companies, but they're nervous of the combination. Actually.
Oh, they're nervous about everything.
We just got to do it.
We got to try it. Yeah. Well, so it's promising. Now let's take some questions from the audience. Yes, Dr. Bertino.
Seems like we have a problem. We have 5 or 6 different therapeutic modalities. We must have a similar number of mouse models. How are we going to make rapid progress without treating patients, with 2 drugs, 3 drugs, 4 drugs? It's going to take forever to really find out the best way to treat a patient with prostate cancer. Is there an avenue that's going to be better? Is there going to be a mouse model where you use tumor from the individual patient to decide the best way to treatment? What are your thoughts about that?
So maybe I can comment on that first. What is interesting to me, and through my work in San Antonio with Eric Rowinsky and Tony Tolcher, did a lot of tubulin binding drug work and mitotic kinase targeting work, is that I believe that taxanes work in prostate cancer primarily through targeting androgen receptor signaling. Now, I cannot prove that quite yet, but there is strong evidence preclinically that the taxanes work in prostate cancer cell lines that are AR positive but not AR negative, i.e. PC3. We have tested a number of mitotic kinase inhibitors in patients and seen no activity. PLK inhibitors, aurora kinase inhibitors, I can go on, KSB. So increasingly, I am convinced actually these drugs are not working through targeting mitosis. Moreover, we have data we're just submitting in a manuscript that all the patients that are refractory to abiraterone, when they progress to the taxane docetaxel, are refractory to docetaxel. We know that we've published data already that abiraterone is much more active pre-docetaxel than post-docetaxel. So there is genuine cross-resistance between the taxanes and abiraterone. I believe what is going to emerge is that actually the taxanes are increasingly likely to be AR-targeting drugs, and we'll be able to identify who will benefit from the taxanes by looking at whether they've had benefit from abiraterone or vice versa. Now, what that means is there may be a subgroup of patients that just do badly on AR-targeting drugs, and that's probably about 20% of patients in our practice, in our trials so far. And that may give us some leverage.
So that raises an interesting question. Is the molecular profile, the gene array profile that you do on a patient after failure on taxane or refractoriness to taxane, the same as after androgen inhibition, androgen deprivation?
So we're doing that work now. Obviously, it's very hard to do mRNA studies. We're doing multicolor fish studies. Certainly, ERG rearrangement alone does not help you by fish. So we have that data, although the patient numbers are not large.
But I guess the question is there a distinct subset of patients who don't respond to androgen receptor, don't respond to taxanes, and have this unique from the beginning?
So the difficulty for us is that the measure of activity is usually PSA.
Yeah.
PSA is a pharmacodynamic reader of AR signaling. And the problem is that drugs that cause a PSA fall may not necessarily be having an anti-tumor effect, but the PSA falls because you switch off AR.
Yeah, right.
So I think it's a complex thing to evaluate because we don't have true radiological measures.
Right.
I think the CDC counts will actually give us some leverage on this, and that's what we're trying to do currently. So we've actually got a trial that the protocol's almost finished, where it's a randomized phase 2 trial. We're going to give abiraterone first, then cabazitaxel, or cabazitaxel first, then abiraterone. And we're going to look at what the response rates are, in first line or second line in those two settings. And we're going to try and pull up biomarkers to, see
which patients
where we can predict who responds.
Progress in both.
Yeah.
Maybe. Yeah.
I'm going to take Joe's comment, but actually slightly reverse it. Because I think you've got a huge opportunity in prostate cancer that's not going to be as easily available in diseases like breast cancer or in colorectal cancer, or indeed even lung cancer now, where those adjuvant therapies and indeed metastatic disease therapy combinations are much, much better established. So the question I would be posing to all of you is there such a thing as standard of care today in prostate? Is that not your opportunity? In other words, go back and really characterize a disease properly. Right. Much as in the last slide as we're finishing, Johan, and sort of begin to propose hypotheses now that you do have active agents that go across a spectrum of different types of activity, from tubulin binders to DNA damaging agents, and start to model those, much as I think Joe was suggesting, to actually look at what's going to interact. Because I could hypothesize, Johan, in relationship to taxanes, that it's just a pump problem. You've actually just upgraded the pump and abiraterone's not getting in, or it's not staying in. So I think there's a real opportunity in prostate because of where you're at in the evolution of treatment. I don't know if you agree with that or disagree. I suppose the big opportunity I see for abiraterone is in the adjuvant setting. It's got to be.
Yeah.
Because
particularly you pointed out there, you can, in the CTC work, you can identify patients who are going to do badly even before they have obvious metastatic disease. They're rising CTC counts and probably rising PSAs. And do we have to wait until they have metastatic disease? Can we intervene at that point?
So we have just included abiraterone in our UK Stampede trial, which is a huge 5,000 patient trial, where we're giving abiraterone upfront with castration at diagnosis to high-risk patients and patients who are diagnosed with metastatic disease at the onset. It's a very complex trial, but essentially that trial I hope will prove that abiraterone can improve survival from first-line setting. I agree with you entirely, Paddy. The opportunities are huge. Yeah. And I think the advantage over breast cancer is that actually in breast cancer, there is a mindset of continuing to give drugs that are essentially inactive. In the 4th, 5th, 6th, 7th, 8th, 9th, 10th line setting with chemotherapy, that mindset does not actually exist in prostate cancer. Yeah. So we have a genuine ability to actually make major changes in the disease. Yeah. And there's a huge number of exciting new drugs that we're testing.
Maybe, Paddy, can I just address that from the perspective of the scientific side? There's a sparsity of relevant models available for preclinical work. And I think the opportunity to develop, advanced preclinical models around genetic modeling, much as what we've heard from Dave Tuvison, I know, and Samson at this meeting, I think that is a massive opportunity in prostate cancer. And when we only get that type of cell line and genetic model, across the spectrum of the molecular stratification we see on that slide, only then will we be able to start to model it all the way into patient.
David, I wanted to ask you a question during your presentation. There must be monoclonal antibodies to IL-8 to its receptor.
Yes. So
why aren't they available to do therapeutic studies?
So Argenx did have an antibody that was directed against IL-8. I think that was has been taken up by one of the buyout of I think it was Amgen was it took it up. It was trialed, as I believe, by Menashe Barelli in a trial in melanoma. But I never found the sort of the outcome of that. I don't think the trial was open very long. I think one of the things that Johan and I will probably agree on is the redundancy in the chemokine system makes it very difficult to argue about targeting the ligand in particular, because what you're going to leave yourself open to is the other chemokines that can activate the receptor. So an anti-IL-8 antibody is not going to take out
multiple ligands for each
redundancy.
Oh, I see.
So one of the things that I would be arguing for is that probably a receptor-directed strategy is probably the key way to go with chemokines. And in that regard, I think we still have a lot to learn about, certainly in the system that I'm looking at, whether it's really a CXCR2-driven phenomena or CXCR1. And again, it's really only when we get the preclinical information and actually challenge those models with those agents will we actually understand that biology.
Okay, we had other questions. Yes, Richard.
Just to revisit the PARP inhibitor stories. Obviously, it's been alluded to quite a lot in this conference about the single agent lethality and P10. Chris did a nice presentation showing the P10 synthetic lethality with PARP inhibitors, which suggests you don't homologous recombination. And yet, the data you've shown, Dave, and also what I understood in the past was that P10 mutant tumours were really resistant. That seems to be a real disconnect there, if you've lost repair. And actually, is there any plan to try the PARP inhibitors as single agents in prostate cancer?
So we've treated about 25 CRPC patients with PARP inhibitors. As you know, and Andrew said earlier, we are starting a trial very soon, just going to ethics, called 2PARP, which is an investigator-initiated adaptive design trial, which is studying olaparib in CRPC. We are seeing some activity in the disease, a single agent. Chris is not in the audience, so I can say this.
And it's not in...
Chris Lord. So, I guess the P10 story is complex, but there is some evidence that P10 regulates STRAT51 expression. I don't think we fully understand how P10 impacts double-strand DNA repair, but I do think there is significant evidence, and I wrote an editorial in Cancer Cell in May supporting this, that actually in prostate cancer there may be DNA repair defects, and certainly Arochinian's data suggests that PARP is involved in ERG transcriptional activity. And there's some evidence that PARP is also involved in AR transcriptional activity. Maybe even PARP is key to ERG and AR transcriptional activity. So I think there is very strong evidence for studying PARP inhibitors as single agents in advanced prostate cancer, maybe even more in combination.
Johan, isn't there a predisposition to prostate cancer in males who are heterozygous for BRCA1?
Thank you for reminding me. So we have published in New England Journal of Medicine, and I think we have 3 patients now in my practice with BRCA2 carrier advanced prostate cancer with spectacular responses to PARP inhibition single agents. But those are rare patients, much rarer than the BRCA1 breast and ovary.
Well, the possibility exists that there's BRCAness, just like with ovarian cancer.
I'm sure there is. In fact, there's published data that there are mutations in sporadic prostate cancers of genes like CHEK2, I think at least 8% of sporadic prostate cancers, and of BRCA1 in sporadic prostate cancer. So I think, we're excited about this.
That's an interesting possibility. Yes.
I wanted to come back to something you said about us not looking at the androgen treatment, the androgen ablation therapy that's been done because it works quite well. Because we've been doing some work with bicalutamide and looking at the effects that it has on the microenvironment immediately after treatment. And it's very clear that initially you get a very significant drop in the oxygen levels in the tumours. Now we're starting at a relatively low oxygen level anyway of about 0.8% oxygen, so these tumours are very sort of hypoxia resistant anyway, but they go down to below 0.1 for about a fortnight. And then they revascularise and they climb again. So you get an angiogenic burst, which doing some work with David has shown that it's probably IL-8 dependent rather than VEGF dependent. So this is a model system that I think is actually really useful. I think it's also important that we understand that this is happening in patients. There is evidence from Peter Hoskin and Roberto Alonzi using bold MRI that the oxygen level does drop in patients that are treated with bicalutamide, but then they gave Zoladex, and we are planning to do that experiment to see they kept the oxygen levels low, or at least blood flow levels as they were measuring. So to me, it suggests that we need to be very careful that this isn't exactly what's driving the malignant progression. In our tumours, within a month, the mice have got lung mets, which are much more significant than if you don't treat them or if you give them a drug that kills the hypoxic cells. So I think we've got a handle here on what's going on. We could do two nice experiments. One, we could do microarrays right across that 28 days to look at molecular changes. We have done some PCR array work, and clearly there are going to be changes because the oxygen levels drop so much. Obviously, various things happen then, and the vasculature changes as well. We've got pictures of the vasculature changing. But we can also then think about molecular targeting agents. I mean, I've come in from this because I was working in a bioreductive drug, but clearly there are molecular targeting agents out there already that we might want to give. There's lots of different drugs there that could be given with bicalutamide and other androgen ablation therapies at that early time point that isn't really done at the moment. Although, Johan, you just said about using abiraterone with the LHRA antagonist, so maybe this is a good reason for doing it. But it would be quite nice to look at it in the model system as well to see if you're actually targeting the things that you want to target.
Comments?
I think hypoxia is a key issue. In fact, Ian Tanner gives this wonderful lecture, particularly on drug delivery in disease, in metastatic cancer, raising concern that actually very often drug is not being delivered to a lot of patients, tumor. So hypoxia is a huge issue, and it's a huge issue for radiation as well as systemic therapy. There's been a lot of work studying hypoxia in patients. It's definitely there. I think the bioreductive drug area has been disappointing overall for us, really, in the field. But we need to get a better handle on it. I mean, Joe, you maybe can comment on that.
I think you were saying about hypoxia. Yes, you're right. I mean, if you're getting this collapse in the oxygen levels and vasculature is collapsing, that's the reason for the drop in the oxygen levels, then you need to be careful when you give anything you're going to combine with an androgen ablation treatment, because you might maybe give it 12 hours before or something like that, or a few hours before, because the vascular collapses very quickly. I think the radiation therapy comes in later, so it's not so much of a problem.
Joe, would you like to add?
Yeah, well, I think against that is the huge body of randomized trial evidence showing that hormone therapy given before, during, and after radiation improves survival dramatically. Sure. I mean, we're talking 15-20% difference in survival, and even short course hormone therapy, both with bicalutamide or with androgen suppression therapy, certainly enhance the benefits from radiation therapy. So obviously there's a lot of process going on. It's well established that the hypoxia story with neoadjuvant hormone therapy, I think when Chris Parker was in Toronto, he had some Eppendorf probe data from patients who are having neoadjuvant bicalutamide. There's no doubt there's hypoxia there, but there's also no doubt that the hormone therapy adds hugely to the benefits from radiation.
Yeah, ultimately. Well, I think that this speaker raises an interesting point, though. If you block the hypoxia response, you might get additional benefits, and we really haven't done a good job of finding drugs to do that. But people are working on it. The disease which is stimulating this is renal cancer because of the involvement of HIF-1 alpha and the angiogenic brisk angiogenesis that goes on there. People are actually looking at inhibitors of HIF-1 alpha now, or HIF-2 alpha, actually. So that's an interesting thing. Another comment about that is that we don't really have a lot of information about the interaction of many of the targeted drugs with radiation. And I think there are several large projects starting now to look at this experimentally to see whether it makes sense to use receptor inhibitors with radiation. Does it blunt the response? Does it accentuate the response? You brought up these issues earlier, and we just don't know a lot about it, but it's a serious possibility. One final thing I'd like to bring up is we've heard earlier from the breast cancer people how an mTOR inhibitor has been remarkably successful in this trial that Gabe Hordabaji described in hormone refractory patients with breast cancer. Has the mTOR inhibitory story been explored in prostate cancer and androgen receptor or androgen deprivation resistant patients?
So Charles Sawyers pursued work many years ago now when he was at UCLA looking at rapalogs in advanced prostate cancer and also in the early stage setting. But there was clear evidence that there was feedback loops involved and that TORC2 may be really important in that setting.
Right.
We now know there's really incontrovertible evidence that there is a yin-yang AR-AKT interaction. And actually, Charles and his group published a paper in Cancer Cell in May, Carver et al., showing that actually if you have high AKT activity, you have low AR. And if you have low AKT activity, you have high AR. We have clinical evidence to support that. We've tested MK206, a very potent AKT inhibitor, as a single agent with castration in castrate patients and shown no anti-tumor activity, but on withdrawing the AKT inhibitor, we've seen withdrawal responses in multiple patients, sometimes even 1,000-fold falls on PSA. And
how do you explain that?
I am convinced that actually, as Charles has shown in his elegant laboratory work, that actually if you remove the AKT blockade and AKT rises, there's this yin-yang, AR expression falls, and therefore PSA falls. So
in some way it downregulates AR?
Yeah, it's feedback loops. So we are now actually just starting randomized phase 2 studies where we're giving abiraterone with an AKT inhibitor or a PI3K-TOR inhibitor. But I think what this implies is that there is a real danger to giving TOR, AKT, PI3K inhibitors as single agents to prostate cancer patients because actually they will upregulate AR signaling and tumor growth. And I guess this is a really key issue.
The other thing I guess that needs to be done is to do these studies in selected subsets of patients, the ones that have
PTEN
loss or the PI3 kinase mutations.
So I was just going to get onto that. All that data was in PTEN loss cancers.
It was.
So that is key. So these studies will look at PTEN as a predictive biomarker of response.
Okay. Are there any other questions? I think we probably reached the end of the session. Patty, one last question.
Just one other question I had. I'm intrigued by the alpha particle both data that looks like it's coming out, but also mechanism of action. I mean, it's a very low emitter, as I understand it. And so the question I have, Joe, is this an anti-tumor effect, or is there something going on in terms of the tumor microenvironment? Because the two don't seem to fit together in terms of the size of the clinical effect that you're getting with something that has such a low penetrance.
Yeah, I mean, it has low penetrance, but what it does penetrate, it kills everything in sight. So it's very, very high LET radiation. So essentially, it doesn't matter whether the cell is hypoxic or not. If it's in the radius of radiation, the cell will not survive that. So I think certainly there's an anti-tumor effect. There's no doubt about that because we certainly see PSA responses. There are radiological responses as well. But I think you're right. I think it's more than that because when you look at the distribution of dose in the bone, it can't all be explained by ionizing radiation hitting tumor. I think there may be a bystander effect. I think pretty certainly there's a bystander effect.
Perhaps affecting angiogenesis and blood vessels.
Yeah, and it may directly affect the sort of the balance within the bone itself, the osteoblastic, osteoclastic balance. So I think there's certainly effects beyond the direct tumor effect, but there's no doubt there is a direct tumor effect.
I think it would also be worth looking at whether the patients that respond most have some underlying DNA repair defect, homologous recombination DNA repair defect, because that may explain why they are so super sensitive to these agents.
Yeah. Well, I'd like to thank our speakers and the supporters of this session. It's been very interesting, and it's remarkable how this field has progressed so much, and you folks here deserve great credit for all that we've heard about. Thank you.